Okay, this is one of our longer ones. I'll try to get through it pretty quickly. Management of patients with musculoskeletal trauma. So a contusion is a soft tissue injury produced by blunt force. It's a big bruise, basically. Pain, swelling, and discoloration, ecchymosis. Oh, my doctor's office is calling me, so pause here. Okay, I'm back. Gotta answer those phone calls. All right, so we were talking about bruising. Strain is just basically where you have a muscle spasm, pain, edema, bruising, and it's graded along how bad it is. It's a pulled muscle injury, basically. Sprain is injury to ligaments and the supporting muscle fiber around a joint. Causes all the things you see there. It can take longer to heal because ligaments take longer to heal. They don't have the vasculature that you would see in muscle or in bone. Dislocation is where basically what it sounds like, the surfaces of the joint are not in contact how they should be. And if you have a traumatic dislocation, that's an emergency, so get them to the emergency room. How do we treat soft tissue injuries? We've talked about this in lab. Remember RICE, rest, ice, compression, and elevation. You would also maybe want to immobilize that injury while it heals and decrease weight-bearing activity on that area. When a fracture happens, it's classified as either open or closed. Open fractures are frequently referred to as a compound fracture. The bone pokes through the skin and it can be seen. That's also like a huge risk for infection, so just know that we have to keep that clean and covered. Make sure you put something over it immediately so that it doesn't get infected. That can end up being osteomyelitis. Let's see. The bone can poke through the skin, but it doesn't always. Sometimes it's a deep wound that exposes the bone through the skin. Closed fractures are commonly referred to as simple fractures. The bone is broken, but the skin is intact. An intra-articular fracture is a fracture that crosses a joint surface and involves some cartilage damage. Fractures to joints are more complicated to treat and heal than a simple fracture, as multiple bones are involved. Bone fragments inside the damaged joint may impede healing time and the efficacy. Here's some pictures of different fractures. The avulsion fracture. These are the common types of fractures that you see in your older adults, by the way. This is your, this one here is, see how you see that dark spot? That's because this person probably has something else like pathologically going on. That dark spot can be malignancy. Or my son, when he was my middle kid, he broke his femur in, I don't know, 2nd or 3rd grade. Maybe it was 1st grade. Actually, I think it was 1st grade. He broke his femur because he had a cyst in the bone. And I forgot what it was called, but it's a common happening in young children up through their teen years, especially boys, where they have these weak points in their long bones that are a cyst, almost like an open area, like an area where bone hasn't filled in. And so it will break, and they think he broke his spontaneously kicking a soccer ball. He kicked the ball, fell to the ground, they heard it snap, and you could see the bone against the skin, but it didn't break through. So it was this type of fracture in the femur. But it can also be due to cancer. So it's a weak point in the bone because there's some type of tumorous thing happening. Then you've got an open fracture here. And this is, see how it's poking through the skin about, I don't know, a little bit up from the pinky finger in that picture? That's an open fracture or a compound fracture. There's all the different types of ones. You don't need to memorize all those. Here's causes of bone fractures. They can be trauma, overuse, and diseases that weaken bones, like we just talked about. The main symptom of fractures is acute, significant pain. They could also have loss of functionality, deformity, shortening of the extremity, especially if you think about a hip fracture. Think about where the femur breaks off at the I can't think of the bone now. You know how I get aphasia when I've been doing too many recordings, and this is like my 7th one today. Anyway, if you break that hip, it doesn't have anything holding it in place because it's broken away from the socket. So now it just floats up into the pelvic area. So I want to just mention here that they're going to have a lot of pain and they're going to have spasms. So we either do some type of little traction until they can get that fixed, or they can use their own body weight and put them on the side of the affected hip area or femur area, and that will use their own body weight to hold that leg in place. Crepitus, that's where you feel that air, and it almost sounds like bubble, that bubble wrap. It sounds like bubble popping when you press on the skin. Swelling, discoloration. Fractures are diagnosed by the patient reporting the injury, and then it's confirmed by radiography. Treatment often involves resetting the bone in place and immobilizing it in a cast or a splint to allow it time to heal. And that has a specific term. I'm trying to remember what it is, so stand by, talk amongst yourselves. It is... Turning the page. Well, I guess I don't care because I can't find it. Yeah, totally can't find it. Then you have... Sometimes you'll have surgery or metal rods that need to be placed inside to reset the bone. Splinting is done because the joints distal to and proximal to the suspected fracture site have to be supported and immobilized while they reattach and heal. So we have to assess neurovascular status before and after splinting or casting. If the patient has an open fracture, we must cover it with a sterile dressing to prevent contamination and infection. We do not attempt to reduce the fracture. That is not our job. Fracture management can be divided into non-operative and operative techniques. Non-surgical approach consists of a closed reduction, if it's required, followed by a period of immobilization with casting or splinting. Closed reduction is needed if the fracture is significantly displaced or angulated. Therefore, the procedure will use manipulation and manual traction. Skin or skeletal. We don't see much skeletal anymore, but sometimes you'll see skin traction. Unlike closed wounds, such as bruises or closed fractures, open wounds are injuries that involve a break in the skin and leave the internal tissue exposed. The skin has an important role in protecting the organs, tissues, and other structures inside the body, so a breach of the skin can potentially invite infection, which is one of the biggest things you want to avoid here. With an open wound injury, the provider will use an internal fixation device to hold the bone fragment in position. That can be pins, wire, screws, plates, whatever they decide. Here's some different techniques and pictures. So you've got all of these metal hanging out, holding these bones in place while that fracture heals. See it here too. This one, there's a pin going down the center of that bone, and there's no need to put this back together here because the pin is going through all the pieces. I should bring in my kid's pins if I can find them, because I still have his pins from when he had, and his pins were external. Like you can see, he has a scar on either side, just above his knee, going through from the interior to the lateral side of his right leg. And I still have the pins, and I think I might have the x-rays even, so I'll see what I can do about that. Uh-oh, I just realized that I don't have this centered right. Sorry, guys. I'm not redoing the whole recording, so you can pull up the PowerPoint if you need to get that to lay right. There we go. All right, good enough. So there's a lot of factors that can affect the healing of someone's fracture. So again, I mentioned this in a previous PowerPoint. Don't ever promise them it'll be healed by a certain time, because look at all the things that can affect it. So if they didn't immobilize it, or we didn't do it effectively, the blood supply is not good to the fracture site, or the adjacent tissues. They have multiple traumas, extensive bone loss from maybe osteoporosis, or maybe from the surgery itself. We had to remove a piece of the bone and now it has to remodel. Infection can set in. They may have poor adherence to the restrictions that we tell them they need to do. There may be malignancies involved, in which case we may never see it heal, or it will be significantly delayed. Certain medications, which I've also mentioned previously, that affect the blood supply to the bones. So one of those is corticosteroids. Another might be antivirals. There's another big one too, some antipsychotic medications. If they're over age 40, or if they have other comorbidities like diabetes or rheumatoid arthritis, which are, that's going to affect circulation. Rheumatoid arthritis, it's an what am I trying to say? It's an autoimmune disorder. So you could have issues with wherever that break was if it's affected by the rheumatoid arthritis. So don't ever promise someone how long it's going to take them to heal. Then you have complications. Those could include wound healing, blood vessel damage, shock, which we've talked about before. Of course, you could have shock because it's a traumatic injury and there's pain involved, and you could have blood loss, all kinds of things. Compartment syndrome, which we'll talk about in the next slides coming up. A fat embolism, that is one of the, it's not as frequent as your book would have you think, but it is a pretty bad complication that can happen, and it typically happens more often in long bone fractures. But it's basically, think about it, there's fat inside. When you break a bone, there's fat inside there, and there's blood vessels. So now the blood vessels are broken. If one of those pieces of fat breaks off and travels into the bloodstream, you now have a fat embolism. A fat embolism, unlike a thromboembolism, cannot be treated with anticoagulants because it's not blood, it's fat. So the only way to remove that is to perform emergency surgery, and but it has the same implications and the same signs and symptoms, basically, of a thromboembolism. Your patient's going to say, I can't breathe. They're going to be very restless and uncomfortable. They may be freaking out a bit. And when there's one thing that I will say that you would see is that they get these bruises that are like petechiae on the chest wall and on the upper arm, typically, if it's a fat embolism. They could also get a DVT, or they could have something called DIC, which we're not going to go into because that is something you'll learn about, I believe, in your, what is it called? Maternity, when you're doing the delivery of children and all that good stuff. OB, that's it. And obviously infection. Those are all complications that could happen. Delayed complications include the bone not meeting up correctly or delayed union, malunion, which I guess malunion is not lining up correctly. Delayed union is it's not joining in the time frame we expected, or non-union, it's not going to and it didn't. Avascular necrosis, which I brought up before, that is necrosis is dead tissue. Avascular, it means no vascular, so your blood supply to the bone dies. Let's see. That is also called osteonecrosis. It can lead to tiny breaks in the bone and cause the bone to collapse. The process usually takes months to years. A broken bone or dislocated joint can stop the blood flow to a section of the bone. Other delayed complications include joint problems, uneven limbs, especially if they break their limb before they have finished growing and it's near a growth plate. That's not going to happen with your older adults, obviously, but it does happen with kids and young adults that have not stopped growing. Complex regional pain syndrome. It's a broad term describing excess and prolonged pain and inflammation that follows an injury to an arm or leg, and heterotrophic ossification. That is the abnormal growth of bone in the non-skeletal tissues, including muscle, tendons, and other soft tissue. When heterotrophic ossification takes place, the new bone grows at 3 times the normal rate, which results in jagged, painful joints. Acute compartment syndrome, I promised we would talk about it later. It is a serious complication. It occurs from increased pressure in a confined space, and it compromises blood flow, causes ischemia and irreversible damage. That damage can occur within hours. The first symptom that you will see your patients exhibit is extreme pain. So the treatment for it is to notify the physician. If they have a cast, it's probably going to be removed. If it's an open fracture, where you just have, if it's an ORIF where they don't have a cast, many times we split the skin open to relieve the pressure that's happening from the inflammation that's occurring. It's called a fasciotomy, and it saves their limb. So as nurses, we're going to be doing a clinical assessment called the 5 Ps. I don't know if that's coming up. If it's not, I'm going to go over it. Here is a cross-section of anatomical compartments, and it helps to show how complex it is to fix fractures due to these complexities. Look at all that stuff that has to happen. Here's a picture of someone that had compartment syndrome and had the fasciotomy done. Look how big their legs swelled up. And it can happen from internal bleeding or swelling of tissues. The pressure decreases blood flow and deprives muscles and nerves of nourishment, basically. And if we don't reverse it quickly, then the tissue will die. Symptoms may include severe pain, like I mentioned, the sensation of pins and needles, and weakness of the affected area. For severe cases of compartment syndrome, emergency surgery is needed. A fasciotomy is a surgical procedure where the fascia is cut to relieve tension or pressure in order to treat the resulting loss of circulation to an area of tissue or muscle. Acute compartment syndrome is a medical emergency, usually caused by trauma like a car accident or a broken bone. Chronic or exertional compartment syndrome is caused by intense repetitive exercise, and it usually stops with rest or changes in routine. So I want to tell you what the 5 Ps are because I don't see a slide. Oh, yes I do. Here it is. Here's the 5 Ps. You need to know these 5 Ps. This is what you as a nurse are going to be assessing your patient for when they have a fracture and whether they have a cast or not. It's neurovascular changes, pain, pallor, so is it pale? And you're going to compare it to the other extremity, if it's especially only on one side, because you want them to look the same or similar. Pulselessness, so you need to check the pulses distal and what is the other word? Distal and above it and below the injury site. Paresia, just what it sounds like. It's pins and needles, basically, and paralysis. So those are the 5 Ps of your neurovascular assessments for your patients. And we want to monitor and treat their pain, describe exactly where it is, when did it start, what's making it better, what's the magnitude, is it, on a scale of 1 to 10, and then treat it with elevation, ice packs, and analgesics. Remember, if we have surgery, we only give them opioids, typically for 3 days. Now, pressure injuries can be a complication of patients that end up having to have a cast, because as their cast is on there longer and longer, it gets really itchy as things are healing. And you have to really make your patients aware and teach them not to use like a ruler or a hanger or whatever they can use to get in there and dig and scratch their skin, because they can actually damage it. And they end up with like a hot spot, and it can be a pressure injury. Then you have disuse syndrome. That's probably more common. And that is basically that however long you had your arm in or your leg in that cast, the muscles begin to atrophy from loss of use, and then you have loss of strength. So of course you can give isometric exercises, which are those ones where you just clench the muscles. You don't have to really move. So we want them to actually do some things so that they can limit the amount of disuse syndrome they experience. But it usually will resolve within time. and physical therapy if needed. Let's see. Remember that these injuries can affect their physiologic functioning, their ADLs. So if they're unable to independently do their ADLs, and you do assess that through using instrumental activity of daily living, we would assess them to see, can they use the phone? Can they shop, prepare meals, do their own housekeeping? Can they drive? Can they take their own medications? Can they manage their finances? Those are the activities we're looking at. When they first do break their leg or whatever, or their arm, if they have to go to rehab for some time to get, function back and regain their independence. If their families live out of state, tell them not to come yet. Tell them to come when they're getting out of rehab, because the things that they may not be able to do, like bend over and get a pan out underneath the stove, or reach high above their head to get the mixing bowl, or whatever they need to do. Those are things that we don't necessarily assess for, but they may need assistance once they get home. Here we go. Signs and symptoms to report. These are what you want to tell your patient. Persistent pain or swelling, changes in sensation, signs of infection or pressure injuries. And also, when are they going to be following up? And when will they get their cast removed? And how do you take care of your skin after you get it off? So those are the things. Let's see what else. An external fixator is a stabilizing frame that we use to hold the broken bones in the proper position. With an external fixator, metal pins or screws are placed into the bone through small incisions into the skin and muscle. These are used for like super complicated breaks typically. And the pins and screws are attached to a bar outside the skin. I'll show you a gnarly picture in a second here. They're used to manage open fractures with soft tissue damage, and they provide support for complicated or comminuted fractures, which is a bone that is broken in at least 2 places. The patient requires reassurance because of the appearance of the device. The discomfort is not as bad as it looks, and early mobility should be happening when they have these devices. It's important to elevate to reduce edema and monitor for signs and symptoms of complications, especially, I would say, infection, because you have openings now all along where those pins are or those rods are, and any of those openings could introduce infection into the bone, so osteomyelitis, which can become septic and would be bad. So if you have an external fixator, which is a steel bar that can be used for fractures of long bones, or it's these rods and pins and screws that are external to the body, we want to clean it multiple times a day. A lot of times just follow whatever the doctor said, but we're going to clean it with whatever cleaning solution was ordered, and at least 3 times a day. Additionally, clean the pins once a day unless your orthopedic care team gives you other instructions. If germs from one pin site get into another pin site, this can cause infections. So don't let anything that touches one pin touch another. That includes gloves, gauze, tweezers, cotton swabs, and anything else that touches the pins. Traction, you don't see this very often anymore, but it's basically where you use the patient's body weight and then a counterweight as a something to hold everything together as it's healing and in the proper place. So it's creating opposing forces to reduce, prevent, or correct the deformity. I'm looking to see. It's usually a short-term intervention. Here's a picture of what it can look like. Oh, the lines of pull are called vectors of force. Don't know if you need to know that, but there you go. There's principles of effective traction. I really don't think you're going to see it very often. I'm just going to tell you that if you have someone in traction, you're not to remove the weight unless you have a doctor's order or it is an absolute emergency. So don't interrupt it in any way. Make sure that the weights are free hanging and not resting on a floor or on the bed. Make sure that there's nothing impeding your view from the patient to the weight. so that you can make sure there's nothing that is changing the pull on that patient's fracture. Then we do skin traction. You're going to see this more often. So skin traction is applied by strapping the patient's effective lower limb and attaching weights. Remember how earlier I mentioned sometimes you can use the patient's own weight to prevent their hip fracture from moving up into the pelvic region before they have surgery. So you could roll them on the affected side, or they could do what's called Buck's extension traction, and that's for femoral fractures. The goal is to put the bone in position to restore normal bone alignment and length, and lessen or eliminate muscular spasms and reduce pressure on nerves. So those are the goals of that. Pelvic traction, I can't remember if I have a picture of that coming up. If I don't, then it's a device that goes around the pelvic region. Looks like underwear almost, but bigger and leather usually. And then heavy weights to ensure that we're stretching the spinal vertebrae and muscles because we want to relieve pressure and pain. Let's see. It's creating vertebrae space to relieve compression and allow the muscles to relax. And then skeletal traction is a treatment method for broken bones. We hardly ever use it. Oh, there's the picture. See, skeletal traction. I guess it doesn't look like underwear because it's really on the upper thighs, but it's pulling, and then look at how many weights are there. It's got to be a lot of weight to kind of decompress the spine like that. All right, and then here is another picture. So we want to maintain skin integrity for our patients if they are unable to get out of bed and move around while they're healing. By the way, you want to get them up and around and moving, but we're going to use a specialty mattress if we need to. Check their legs, heels, elbows, and buttocks for pressure injuries, especially if they have to be in the same position for a bit. Position a rolled up towel or pillow under the heel to relieve potential pressure, or put on those waffle boots that I talked about in lab. Encourage them to reposition themselves if they are able to, and complete pressure area care every hour. Let's see, remove foam strip and bandage once per shift to relieve potential damage from pressure and observe the condition of their skin. So this is for the patient's in traction. Minimize the sheets, wrinkles, and aim to keep dry to reduce potential skin damage. Assess and document the condition of the skin throughout care and the progress notes in the care plan. Ensure that the pressure injury prevention score and plan is assessed every shift and documented. And remember, if you're doing your Braden scale and it's below 19, then you need to be doing some stuff to show you we're preventing skin breakdown. Look for signs and symptoms of DVT. Look for signs and symptoms of infection. Do your 5 Ps, all of that. I think we just talked about all that. I feel like you can read. I'm not going to read it to you. What's next? Oh, of course they're going to have anti-embolism stockings on, or compression devices, or they'll be on anticoagulant therapy. We want to teach the patient how to do pin care and exercises to maintain muscle tone and strength while they heal. Why does it keep going back to this pressure injury thing? I guess I can't click right. We also want to look at if they're in traction, they're not moving around, how's their anxiety? And we want to help them with their self-care, letting them do as much as they can. Atelectasis is a collapse of all or part of a lung, and is caused by a blockage of the air passages. So we're going to, they can get that from, I am saying a lot of ums in this video. I'm sorry, guys. We're probably so long into this too. Yeah, 30 minutes. Sorry, it's so long. Anyway, let's see. They can get it from anesthesia. Their bases of their lungs get really sticky with the surfactant and the alveoli. It gets sticky. So we want to encourage them to use their incentive spirometer to avoid atelectasis, to avoid lung collapse. Also, if they have pain, they have shallow breathing, or if they have underlying lung disease already, they can get pneumonia. So many complications from just laying there. So they can also get constipation. If they're taking pain medications and they're immobile, those are two huge reasons why. So what are we going to do to prevent constipation? We're going to give them stool softeners, ensure that we have adequate fluid intake. If they can drink, then encourage oral intake. If not, IV fluids, unless they have a contraindication such as fluid restrictions for kidney or heart failure. Anorexia. They sometimes will get depressed to the point where they don't want to eat. So we need to be assessing them for their mental status and how much are they eating. Urinary stasis is where they are not able to move. So their urine is sitting in the bladder and not moving as it should through the bladder and the kidneys, which can lead to urinary tract infections. They also can get an infection at the site, any open skin or wounds. It can also be in the surgical site itself if there is contamination from surgery itself. And then venous thrombosis, embolism is another complication due to prolonged bed rest. So the blood is pooling and development of a blood clot, DVT or PE could happen. So all those things we need to be monitoring for and treating and preventing. Clavicle. I don't know why we're doing this because I don't know anybody with a clavicle fracture who ends up in the hospital, but just know that we're going to have exercises for the elbow, wrist, and fingers. Do not elevate the arm above the shoulder for 6 weeks. And they're going to have slings or braces to limit their activity and movement until they've adequately had it immobilized to heal. And there is what the fracture looks like. And there's an immobilizer or something that kind of holds it in place. That's one example. And then here's some proximal humeral fracture immobilizers, different ways to do that. That's a brace. These are some exercises for range of motion. And some more nursing interventions for fractures that are in the arms and wrists and hands. Pelvic and hip fractures are more what I feel like we'll be seeing. So it depends on the type and extent of the fracture. I will say this, if they have a hip fracture, they do it, and they do the surgical repair in a couple different ways. So if they do it, I need to look at my notes because I can get them confused pretty easily, and I want to make sure I say it right. If they do a lateral approach, then it's going to be contraindicated for the patient to move forward more than 90 degrees, and they cannot cross their legs. So they're going to have that abductor pillow. So that looks like Gumby. That's what I always called a Gumby pillow. And that goes in between their legs and it gets Velcroed across their legs to keep their legs separated a bit and prevent them from crossing their legs. And then if they have an anterior approach to the surgery, they cannot go back more than 90 degrees. If they do go forward more than 90 with that lateral approach, or they go back more than 90 on the anterior approach, then they can dislocate that fracture and have to go back into surgery. Or the surgical repair. And there's a picture of the pelvic region. There's a picture of some fractures. Unstable pelvic fractures, femoral fractures, so where you've got the femur breaks off from the neck of the trochanteric region and the capsule for that hip. When that breaks off, then the femur tends to drift into the pelvic area, and that's what causes all the spasms and the pain and the shortening of the limb. So we're going to want to preserve muscle function and improve circulation by doing lower leg, foot, and hip exercises. Physical therapy treatments will focus on improving range of motion without putting excessive strain on the healing bone or ligaments. And then as it heals, muscle strengthening exercises as well as range of motion and balance training will all be used to increase movement and mobility. We also want to get the patient up as soon as possible because early ambulation stimulates healing. It also helps reduce other complications like DVTs and all of the complications that go along with being in bed. You can go back a few slides and hear them again if you need to, or read them again. So physical therapy, ambulation, and weight bearing are all prescribed for the patient. Active and passive knee exercises are begun as soon as possible to prevent restriction of knee movement. All right. And then these are the different things you need to be looking at with your patients with a fracture of the hip. I think we've talked about all of these before, but I'm not going to read them to you because you can read. I'm looking to see if there's anything I need to say. That neurovascular assessment is the 5 Ps. And there's some complications with a hip fracture. AVN that you see right here, that is avascular necrosis, which is where the blood supply in the bone dies, and it can cause death to the bone itself. And then VTE, remember, that could be from a fat embolism, especially long bones and pelvic fractures. They're the most frequent causes. And they can also have a pulmonary embolism as well, of course. All right, then we have the goals for the patient with hip fracture. You can read them. These are occupation-related injuries for you as the nurse. These are the most common injuries for nurses. So, save your back, work smarter, not harder. If in doubt, get another person to help you. Use the right body mechanics. Amputations. We don't see as many as we used to, but as a matter of fact, I hardly ever. I've had patients that have previous amputations, but I haven't had a lot that had an amputation. Remember to use your figure 8 to do the wound care. We need to make sure that we're modeling or remodeling where the patient's residual limb is located so that we can fit them with a prosthetic device. We know all the things that we learned in lab. Review that video if you need to teach your patient how to care for the site and when they need to contact their provider. Remember not to call it phantom pain. I'm looking at what else is in here. Oh, one of the biggest complications with an amputation, because it's such a large surface area that's been removed, is hemorrhage. Remember my days 1, 2, and 3. I think hemorrhage might actually extend beyond day 1 because of the surface area of the wound that it has to heal. But also infection is huge. Pain is big. DVT can happen. All of it. And then arm amputations above the elbow, below the elbow. Always assess their psychological state because they may be having a difficulty coping with the altered body image. They could have skin breakdown, joint contracture. So we want to make sure they're doing range of motion exercises and get into, exercising the muscle region as soon as they can so that they don't have joint contractures happening. These are some of your goals for your patient with an amputation. And how to relieve the pain from an amputation. Working with your patients to relieve their psychological effects from losing a limb. Promoting independence. Always, always, you guys, we promote their independence. We want them to do for themselves as much as they can. And then this is for the interventions we would do, monitor the vital signs for changes in blood pressure, because what does that indicate? If their blood pressure drops after surgery, it's a hemorrhage. Check somebody put stump dressing in these notes. Shame on them. I said we never called a stump. Check the residual limb dressing regularly. And make sure that it's marked with the date and time. And make sure if you see any shadowing or bleeding, it needs to be reported to the physician. Check the proximal end of the residual limb dressing for swelling, because we don't want that to be too tight. Check it for the 5 P's. So what are those? Remind yourself. Don't call it phantom pain. Encourage them to do their prescribed exercises to preserve range of motion in the affected limb and to strengthen the remaining limbs. And then remove and reapply the bandage according to the instructions as often as needed. And I feel like that's pretty good. Yeah, that's it. Finally done, 40 minutes in.